multiple times, every day, all the time. I believe that I have experienced chest wall rigidity in my patients perhaps 3 times, all right, in about 10 plus years. It does happen. It's very scary. You cannot ventilate the patient, all right? If you can't move their chest wall, you're not going to, be having a party, even if the patient is intubated, okay? So the first thing you do, obviously, is positive pressure. If your patient's not intubated, that's bag valve mask, okay? Sometimes that's enough. Sometimes, although the patient is experiencing difficulty, with positive pressure, you can overcome it. You can effectively ventilate enough. You can keep their sats up, all right? And probably, by the time you're able to get either a reversal agent or a paralytic, and draw that up, usually the episode is resolved, okay? The other choice, therefore, is to reverse it, which, if you're not ventilating, but your patient's in pain and that's why you gave the drug, then your patient will probably complain less about hurting again versus being dead. The other thing that you can do, if you have a good airway, is to use a paralytic, all right, and this will overcome the chest wall rigidity, all right, although, like I said, most of the time it is relatively a short-lasting event, and if you can administer positive pressure, by the time you get other meds drawn up and ready to be given, it might actually have subsided, okay? The dose range for fentanyl, 1 to 3 micrograms per kilo, okay? Again, the advantage of fentanyl is that it does not have the hypotension, okay? Remember, the larger the dose, the more you're going to affect the respiratory drive, okay? And the faster you give it, perhaps this is what gives us the chest wall rigidity. So those are things to consider, all right? Metabolism I'm going to save just for the paralytics, okay? We won't go into that on every single drug, all right? So that's fentanyl. Okay. So now let me change the order a little bit and stay with the same class. We'll talk about morphine, which is kind of like the original narcotic, I guess. All right, onset of morphine, it's not that far behind fentanyl, okay? Probably within 2 minutes, all right, you're going to, the patient's going to be able to, have some relief. Peak, probably around 30 minutes or so, okay? Duration, 1 to 4 hours. Side effects, all right? Decreased blood pressure can be significant. And again, respiratory depression. Okay, those are the biggies. True for most, again, true for most of the drugs that either have anything to do with pain or sedation. Dose range. Usually, the standard dose is 0.1 mg per kg, all right? If you're worried about the degree of respiratory depression in a patient who you don't have an airway in, worried that you might tip the patient over and make them hypotensive, if your concern is that they're going to be prone to do that, then you give less, all right? You can try half that dose, all right? Sometimes we round up. Even in big patients, in general, I would be hesitant to give more than 3 milligrams at one point in time as a first dose. Now, if the patient is not naive, all right, to narcotics, and you're told that they've been getting 5 milligrams every dose and the patient's in significant pain, then yes, that's fine if you know that it doesn't, give them problems. It's fine to start with that if you have a proven history. But, as a first time out, I would be quite hesitant to, give an adultish patient more than 3 milligrams at one injection, okay? All right, so that's morphine, okay? Now, so we've done fentanyl, we've done morphine. All right, let's talk about thiopental just to change things up, because it's not a drug that we use every day, okay? I do think, however, again, because of what you do for transport, that you should know that this drug profile, because indeed out there in the community, especially with certain types of patients, and especially with primarily adult caregivers, you may be picking up patients with some sort of regularity that are either getting or have received thiopental, all right? Thiopental is a barbiturate, okay? It's, together with pentobarbital, with phenobarbital, okay? The beauty of thiopental is its onset, okay? You give somebody some IV thiopental, and they are probably responding within about 10 seconds of that dose being given. Its peak is roughly 60 seconds, all right? Its duration in general is less than 3 minutes, right? In some types of patients, it could last a little bit longer, but it is truly a short-acting agent, okay? Side effects. You will absolutely get loss of your airway protection, okay? You will absolutely experience a drop in your blood pressure, okay? You need to know those two things. Dose range is general 1 mg per kg. Again, that's something to keep in your little pocket cheat sheet. But this drug can be extremely useful in the right situation, okay? It is usually used for rapid sequence intubations, primarily with people who have experienced head trauma or some other sort of trauma, okay? It's a beautiful drug when used correctly, and like I said, especially out there in the community with primarily adult-based physicians, you should know this drug, because many of the outside people may have used it on the patient, okay? And if you're ever asked to assist, then you need to know what the expectation, the effects of that drug are going to be. All right. Next, we will look at the benzos, okay? Let's look at Ativan, and just for fun, we can look at Versed at the same time, okay? Onset. Most of you have come upon a seizure patient. What's your first line of choice often for them? It's usually Ativan. Do you have to stand around for 10 minutes before it takes effect? No, okay? In general, it's probably, let's just say 60 to 90 seconds, okay? Versed may be just a bit faster, okay? Its peak effect, Ativan, probably 30 minutes to an hour.